Assalamu alaikum wa rahmatullahi wa barakatuh. Welcome back to the channel of Standard Medical Notes and Lecture. So till now we have discussed about the non-insulin pharmacotherapy of type 2 diabetes mellitus. So in that we have discussed that so first line therapy is lifestyle modification and metformin. Then first you will consider the comorbidities, particularly any cardiovascular or renal comorbidity. Depending upon that, you will choose either GLP-1 or SGLT2 inhibitor based upon the cardiovascular and renal comorbidity, irrespective of the levels of HbA1c. So if no independent priority, meaning if no comorbidity exists, then we will focus on specific patient goals, like whether the patient is overweight, then we will focus on weight loss, or whether the patient has a context where the patient is placed on a high risk of hypoglycemia, then we will decide upon that drugs. And then if cost is a thing, then we will decide the drugs like sulfonylureas and TZDs. Now we will move on towards insulin pharmacotherapy. Okay. So before moving on to the how we give insulin pharmacotherapy, we should know the physiology and the concept behind giving insulin pharmacotherapy. So as you can see here, physiological secretion is there is a 24 hours, you can see this blue line, 24 hours basal insulin secretion by the body, 24 hours basal insulin secretion by the body. And when you take food like breakfast or lunch or dinner, at that time the insulin secretion is increased, that is known as prandial insulin secretion. Okay, so these are increased insulin secretion when you take some food. So there will be a baseline insulin secretion, and when you take food there will be a exacerbation of insulin secretion in order to decrease the in order to increase the uptake of glucose by the cells. Okay, so that is the actual physiology of insulin secretion. So our main goal will be to cover this basal insulin secretion and then this prandial insulin secretion. So this will be the goal. So likewise we give the insulin therapy to the patient mimicking the physiological nature. Okay, we will give a basal insulin which will have a long half-life without any spike, and if the fasting plasma glucose and HbA1c are met, then we will not plan any prandial insulin. But if either of these two, if fasting plasma glucose is not met, then we will increase the dose of HbA1c. But if fasting plasma glucose is met and HbA1c's target is not achieved still, then we will plan for prandial insulin doses. So either in the breakfast, if the patient takes good food in breakfast, or in the lunch, or in the dinner, we start this prandial insulin dose. And still if at one food time, either breakfast, lunch or dinner, we start this prandial glucose, and still if the HbA1c target is not increased, means if HbA1c target is not reached, then we will move on to other food intake times. So that's how we give this insulin therapy. Okay, so the goal of therapy is to replicate normal pancreatic function. So the basic funda of basal insulin is it will not have any spike. So this is a very good insulin to mimic the basal insulin secretion, and then short acting insulins will be given to cover the prandial insulin secretions. Okay, so physiology and concept behind insulin therapy we have discussed. Now, what are the indications for insulin therapy? Indications in type 1 diabetes mellitus, it is absolutely required because there is no endogenous insulin secretion. But in type 2 diabetes mellitus, it's not a absolute indication. So main thing is there should be significant beta cell exhaustion in type 2 diabetes mellitus patient, then only insulin is required in this type 2 diabetes mellitus patients. So where that beta cell exhaustion is seen? So number one is severe symptoms of glucotoxicity, for example like in diabetic ketoacidosis or hyperosmolar hyperglycemic syndrome. In these two states you have symptoms of glucotoxicity. Or if the patient has extreme hyperglycemia, for example like patient is having HbA1c more than 10% or blood glucose level more than 300 milligram per deciliter. So at the time also you will start insulin. So the second indication. Third indication is evidence of catabolism. Patient has unintentional weight loss. So if the patient has weight loss, then also you will then also insulin is indicated in patients with type 2 diabetes mellitus. Now fourth indication is progressive beta cell failure refractory to combination of non-insulin therapy. So when pharmacological agents fail to meet the targets, then also you will try for insulin therapy. You will start the insulin, not try, you will start the insulin therapy. So there are four conditions. Number one is in the crisis states like in diabetic ketoacidosis or hyperosmolar hyperglycemic state. Number two is when there is extreme hyperglycemia, HbA1c is more than 10% and blood glucose level is more than 300 milligram per deciliter. Number three is when there is unintentional weight loss, and number four is when pharmacological agents fail to achieve the targets. So that's about the indications of insulin therapy in type 1 and type 2. So we should know about the different types of insulin which we give. Okay, remember there are 4 types of insulin. There is number one, rapid acting analogs. So this is not insulin, it is an analog. Okay, and there is short acting insulin, intermediate acting insulin, long acting analogs, and ultra long acting analogs. So see here, rapid acting analogs are Lispro, Aspart, Glulisin. Onset is 5 to 15 minutes. Peak hours 1 to 2 hours, and duration they will act for 3 to 5 years. So so these rapid acting analogs are very good for prandial dose of insulin. So they will produce this spike very similar to our physiological spike, insulin spike when we take food by oral route. Okay, and short acting are somewhat late, like regular human is a short acting insulin. Onset is 30 to 60 minutes, peak is 2 to 4 hours, and duration is 6 to 8 hours. So the curve will be something like this. So it is not peaked like this. Oh, it will be acting somewhat longer. Okay, and intermediate acting insulin example is non-protamine Hageman insulin. So this is 2-hour onset, peak is 4 to 12 hours, and duration of action is 18 to 26 hours. So this is not used for actually your prandial insulin. This is used as a basal insulin. Okay, but this is not ideal. So this is not as a ideal basal, and this is not a ideal prandial. So ideal prandial is Lispro, Aspart, and Glulisin, and ideal basal is this long acting or ultra long acting analogs. So long acting analogs are Glargine unit 100. This unit matters. So if you are taking a vial of unit 100, you should take a syringe of unit 100 only. You should not take a syringe of unit 40, otherwise patient will end up with hypoglycemia. Similarly, there will be unit 300 also, Glargine. So at that time you should take a syringe of unit 300 only. You should not take unit 100. Okay, so this should match. So that point should be kept in mind. So for long acting insulin, examples are two, that is glargine unit 100 and detamir insulin. Glargine unit 100 and detamir. So onset of action is 2 to 4 hours. There is no peak. I said no. These are basal insulin. They will not have any peak. And duration of action is 24 hours. That means you should give once a day. Okay. So this will be the curve actually. And dugludex and glargine unit 300. Dugludex, glargine unit 300. There is no peak. Onset of action is 1 to 2 hours. And duration of action is actually more than 40 hours. More than 40 hours. These are ultra long acting insulin. And you can see here the curve will be like this. So these are the examples of insulin. So there will be ultra short acting analogs, short acting insulin, intermediate acting insulin, long acting analogs, and ultra long acting analogs. So for rapid acting insulin, examples are Lispro, Aspart, and Glulisin. But the drawback here is these ultra short acting analogs are costly. Okay, so compared to this short acting insulin like regular insulin, and the intermediate acting insulin is non protamine H1 insulin, NPH insulin. So that is actually used as a basal insulin. Long acting insulin example is glargine unit 100 or detamir, and ultra long acting insulin example is dugludex and glargine unit 300. Okay, that's about the small introduction about insulin, different types of insulin. So there is one rule here. There are two things to remember. There is something called as 1800 rule and something called as 500 rule. This 500 rule is actually used for calculation of something called as CIR. Okay, carbohydrate insulin ratio. So CIR is nothing but 1 unit of insulin covers so the CIR says you about 1 unit of insulin covers how many grams of carbohydrate, consumed by the patient. And 1800 rule, or 1800 you can say, it has 1500 also in some cases depending upon the type of insulin you use. So 1500 rule is used to calculate insulin sensitivity index. So that will say you 1 unit of insulin decreases how much amount of blood sugar level, BSL. So these two indexes are used. These are advanced strategy of using insulin. So this is somewhat difficult, but we will learn the traditional easy strategy also and this advanced strategy also. Just to remember CIR and insulin sensitivity index. Now step by step we will learn about how to start insulin therapy. So patient meeting the indications for insulin. As I said, for patient with type 1 diabetes mellitus, it is absolutely required. Their pharmacological agents will not work. In type 2 insulin, there are some criteria. One criteria among the common criteria is one is crisis like DK and HHS, and resistant to pharmacotherapy. Second, when the HbA1c is more than 10% or blood glucose level is more than 300 milligram per deciliter. And the third one is when there is catabolic state. Okay, that's about type 2 indications. So how you will start? So basal insulin initiation foundation. So first you will start basal insulin. Okay, how you will start? Choice. So a long acting analog is preferred like glargine unit 100. Okay, detamir, degludex. So this is ultra long acting because they don't have a peak. That's why they are used as basal insulin. So what should be the insulin dose? So the initial dose should be either. So this is the traditional method we are discussing. So just remember there are two methods. So easy and traditional method. Second one is advanced method. We will learn about the advanced method in the coming slide. So this is the easy and traditional method. So initial dose, either you will start the basal insulin dose. So this is the, so we explained, no, there should be basal insulin and there will be prandial insulin. Okay, like this. So we are talking here about this thing, this basal insulin. So one, either a long acting analog or ultra long acting analog we will use. So initial dose is either 10 units per day or 0.1 to 0.2 units per kg per day. For example, if a patient is 60 weighing 60 kgs, then average if you take 0.15, then it becomes 6 into 15, 6 for the 30, 6 into 6, 90. So 90 units per day the patient will require. Okay, so that's the example. Okay, so now the titration, how you will titrate? 2 unit rule. So you will titrate, you will increase by 2 units, and it will be every 3 days. So there are two methods. Either you will increase the dose of insulin by 2 units every 3 days, or you will increase by 10%, 10 to 15% twice weekly. And whenever you use basal insulin titration, you will see the fasting plasma glucose. Okay, fasting plasma glucose, and the target is less than 130 and more than 90. Okay, so 90 to 130 is the target. This is the target when we are using basal insulin. Okay, so is reached consistently. Okay, and one point to remember is, if unexplained hypoglycemia occurs at any point of time to the patient, then immediately reduce the dose of basal insulin by 10 to 20%, or you can say 2 to 4 units. Okay, immediately reduce the dose of insulin by 10 to 20% whenever you see a hypoglycemia, unexplained hypoglycemia occurs. Okay, so that's how you start basal insulin and titrate by seeing the fasting plasma glucose. Okay, and whenever if you suspect any unexplained hypoglycemia, then you will reduce the dose by 10 to 20%. Then when the target is met, if the target of fasting plasma glucose is met, then you will see HbA1c now. If the HbA1c is not elevated, meaning that HbA1c is in the target, say 7 or less than 7.5%, then continue the current regimen, meaning only the basal insulin should be maintained if fasting plasma glucose is 80 to 130 and HbA1c is achieved without any prandial insulin. But if fasting plasma glucose is at its target but HbA1c is still elevated, then you will add a prandial bolus prandial bolus dose. Okay, so now we will learn about prandial insulin. So how do you initiate? Add a rapid acting analog like Lispro aspirin, ideally, or you can use a short acting insulin like regular insulin before the largest meal or the highest carbohydrate meal. So some patients will eat more in the morning, some patient will eat more in the lunch, some patient take food more in the evening. So depending upon that, before the largest meal of all the 3 meals, the first prandial insulin should be given. Okay, only one time. So initial dose, either you give 4 units or 10% of the current basal dose. 10% of the current basal dose. Okay, safety adjustment. If HbA1c is less than 8%, this point is important. If HbA1c is, so a fasting plasma glucose is achieved by your basal insulin, but HbA1c is not in the target, but it is less than 8%, but not in the target still, not less than 7%, then preemptively, meaning without any condition, decrease basal dose by 10% or 4 units on day 1 of starting the prandial glucose. For example, you have started a long acting insulin like glargine, you can say. glargine unit 100 you have started, say some 20 units, and the fasting plasma glucose is achieved, but HbA1c is not in the target, but it is like for example 7.8%. so here is the point. So it is not in the target, but it is 7.8%. 7.8% is less than 8%. So what you will do in this condition, before giving the prandial dose insulin, you will reduce the dose of this glargine unit 100, 20 units. You will reduce the dose by 2 units, or you can say 4 units, 10%. So 10% of 20 is nothing but 2 units. Okay. So you will reduce the dose and you will start the prandial insulin. So that is the point here in the box it is given. Okay. Now comes how you will titrate. So this requires careful attention, otherwise you will not understand this. Okay. How you will titrate? Increase prandial dose by 1 to 2 units, again 2 units, twice weekly, every 3 days, until 2 hour post-prandial goal is met. So I said, for basal glucose adjustment, for basal insulin adjustment titration, you will see the fasting plasma glucose level, but for prandial insulin adjustment, what you will do, either you will see a 2 hour post-prandial glucose level or fasting glucose level of the next meal. Meaning, suppose you have started the prandial insulin in the morning, then you will see the fasting blood glucose level of the lunch. So this fasting blood glucose of the lunch will serve as a titration target for your prandial glucose level of which you give in the morning. Okay. So either of the two methods you can use. Either you can see the 2 hours post-prandial glucose level and titrate the prandial insulin level, or you can see the just before lunch, meaning the next meal fasting glucose level, fasting blood sugar level, next meal fasting blood sugar level. By seeing that next meal fasting sugar level, you will adjust the dose of the previous meal prandial glucose level. Okay. So this is the traditional method. Okay, this is the traditional method of giving insulin, and this is the easiest method, and this is the method which physicians follow, even the experts follow this method. So this is somewhat difficult method. So advanced Basal-Bolus dosing, so it requires mathematics. So what you will do here, you will calculate total daily dose of insulin. How? For type 1 diabetes mellitus, it is actually 0.4 to 0.5 units per kg per day, and for type 2 diabetes mellitus, it may require more than 1 to 2 units, but actually in type 1 type 2 diabetes it is 0.1 to 0.2 only, 0.1 to 0.2 units. So remember, for type 2 diabetes mellitus, the total daily dose is, if the patient is not taking any pharmacotherapy, then the dose is 0.5 units only. But if the patient is taking any pharmacotherapy, meaning oral drugs, then the dose is actually 0.1 to 0.2 in type 2 diabetes mellitus. So that thing you have understood. So first you will calculate the total dose, daily dose of insulin. Total daily dose of insulin you will calculate. Okay. So for example, if the patient is weighing 70 kgs, okay, so the total dose 0.5 units per kg, it will become 35 units. Then what you will do, you will split this dose 50%. So 50% of the basal, 50% you will give it as basal, and 50% of it you will give it as bolus dose before the meals. Basal as long-acting analog, which suppresses the hepatic glucose, meaning the fasting plasma glucose, and 50% bolus, meaning the just 2 hour ppbs or just next meal fasting blood sugar level. Okay, so that is rapid acting. So in this example, so it is 35 units. You will split. So basal you will give it as 17.5 units, and bolus you will give it as 17.5 units. So basal, if you round it, it will become 18 units, and 18 units will split into 3 meals. For example, in morning you will give 10 units. So sorry. In morning you will give 6 units, breakfast, lunch 6, and then evening prandial it is 6. So 6 into 3 is 18 units. So 50% of the total daily dose you will give as basal, and 50% you will split into 3 prandial insulin doses. Okay, now same titration, how you will titrate. So here the difference, so this is one difference. The second difference is this: titration you will do by this CIR and ISF, Insulin Sensitivity Factor or Index, you can say. So how you will calculate CIR? So 500 divided by total daily dose will give you CIR. For example, in this case, 500 divided by total daily dose of 35 is approximately 14. That means 1 unit of insulin covers 14 gram of carbohydrate. 1 unit of insulin covers 14 gram of carbohydrates. Now you will calculate the CIR now. Now next coming to ISF, Insulin Sensitivity Factor. So what you will do, you will divide 1800 by total daily dose. So here it is 35. So approximately is 51. That means 1 unit of insulin will drop the blood sugar level by 50 milligram per deciliter. 1 unit of insulin will drop the blood sugar level by 50 milligram per deciliter. Now for regular insulin, you will not use 1800 milligram rule, but you will use 1500. So for long acting insulin like basal insulin, you will use 1800, but for regular insulin you will use 1500. Now, so one change which is advised by the latest guideline is, don't maintain a static dose of insulin in before the meals. Meaning, previously they use sliding method. What is sliding method? So for particular range of glucose, for example, if the glucose is 100 to 150, give 1 unit of prandial insulin, 2 units of prandial insulin. If the glucose is 150 to 200, give 6 units of prandial insulin. So this was fixed. So patient, what it used to do, patient used to measure his range just before food, and depending upon the range, there was a first fixed unit of prandial insulin, and he will used to give that fixed unit according to this sliding method. So similarly for for 200 to 250, it may be for 8 units, like that. So now the guidelines are stressing on don't use a fixed dose of insulin. Instead, you calculate a total meal dose depending upon the grams of carbohydrate consumed by the patient. Okay, so that is the main thing which the modern guidelines suggest. So how you will calculate the total meal dose? So it is this is the formula: total grams of carbohydrate consumed by the patient divided by CIR. Okay, 1, that is added to current blood glucose by target blood glucose divided by insulin sensitivity factor. So by adding both these two, you will get the for example, total dose before a meal, grams of carbohydrate consumed is, for example, it is 50, divided by CIR is approximately 15. You can take round off value. Okay, and 45 you can take this as grams of carbohydrate consumed by the patient. Take it as 45 to make it easy, divided by CIR, here it is 14, plus current blood glucose, say it is you can say it as 245, and say the target is for example it is target blood glucose is less than 180, so that is you can take it as 160 you can take it as, so divided by 50. Okay, so 240 minus 160 is 40 plus 45, so it is 135. So 135 by 50. Okay, so here it is, you can take it as round of 15. 15 ones are 15 threes are, so it is 3. Okay, so this is 5 tens are 5 2s are 10, 5 7s are 35. Okay, 10 3s are, okay, so 3 plus 3 plus 3 is nothing but 6. That means the total meal dose is 6 units. So that's how so this is the method to calculate the total meal dose, but it is a complicated method. But so the easiest method is the previous method which I discussed. Start basal insulin start by 10 units and titrate by saying fasting plasma glucose. Then if HbA1c target is not achieved, then you start the prandial insulin before the largest meal of the patient and titrate based upon the 2 hour post prandial glucose or the next meal fasting blood sugar level. So that is the traditional and easiest method. This is a somewhat complicated method, but one important thing here is this one. I think it is this one, this insulin sensitivity factor, because by this we will know that how much unit of insulin, 1 unit of insulin decreases how much milligram per deciliter of blood sugar level of the patient. So by that we can have some prediction about how much the patient can, how much we need to give the patient the insulin. Okay, so this is a complicated and advanced method of insulin dosing. These are the 2 methods. Now here one point was how you will calculate the grams of carbohydrate. So that is again a complicated thing. So there are 3 methods. So one is hand method, one is diabetes plate method, one is something called as carbohydrate choices. So carb choice is nothing but 1 carb choice is equal to 15 gram. That's all. 1 carb choice is equal to 15 gram, meaning you are grouping 15 grams, 15 grams, 50 grams like that. Okay, so hand method is if you make 1 fist, so that is equivalent to actually 1 cup, that is 30 gram of carbohydrates of starch and grains. Tight fist is half cup, open handful is half cup. So like that is hand method. Okay, diabetes plate method, say the patient say the patient to take the food in such a manner that half of the plate should be non-starchy vegetables and 1/4 should be starch and 1/4 should be your protein. Okay, so if the patient is following this method, then patient is taking approximately 45 to 60 gram of carbohydrates. 45 to 60 gram of carbohydrates. That is, so this is the easiest method for calculating grams of carbohydrate. If you say the patient like that, so you can take patient is consistently consuming 45 to 16 gram of carbohydrates. Or the other method is like this carb choices. So like grains and starches is 1/3 of cup, cooked rice or pasta, 1 slice of bread, one small potato is equal to 15 gram. 15 gram is equal to fruits, 1 small apple or banana, half cup canned food, 17 grapes. 15 gram is equivalent to 1 cup of milk. 15 gram is equivalent to half cup corn peas. So your so this carb choice means 15 grams, 15 gram rule. You can say it as 15 gram rule. So the easiest among this hand method, plate method and carb choice is the diabetes plate method, because you are instructing the patient and patient will be taking, and you will know the patient will take 45 to 60 grams of that. So by that you will know the number of grams of carbohydrate patient taking, and that by that you can calculate the total meal dose. So that was the advanced method which we have discussed now. But the first method, traditional and easy method, and most physicians which follow, is the first method. Okay. Now one example. So without example, we will not understand this insulin. So we'll take an example, a case scenario. Okay. Suppose a patient of type 2 diabetes mellitus who is 60-year-old male who is on metformin and dapagliflozin is taking 10 mg per day. His HbA1c is 9.5%, which is more than the target HbA1c, and fasting plasma glucose is 190. So both are above the target. So it is more than 130, it is more than 60-year-old means more than 7. Okay. So now here the indication, oral agents are sufficient. If they are not sufficient, then maximize the oral agents. If after maximizing the oral agents still the patient's targets are not met, then you first initiate the basal insulin. So how you will start the initial basal insulin initiate in this patient? So as you can see here, the funda of initial basal insulin is it will decrease the hepatic glucose production. So hepatic glucose production is responsible for fasting plasma glucose. So goal is to control hepatic glucose production overnight and normalize the fasting plasma glucose. The target is 80 to 130 milligram per cell. So we are discussing here traditional method, not the advanced method. So we'll start with a long acting basal analog, Dargin unit 100. Starting dose, either we are starting either 10 units or average of this one, it is nothing but 0.15. So the weight of the patient is 80 kgs, 80 into 0.15 is 12 units. So we have started the patient on injection insulin glargine 12 units subcutaneously once daily at bedtime, not at the dinner time. Remember, it is at the bedtime. Okay. So we have started. Now, how you will titrate? Step 2 is titration. Fixing the fasting first. So fasting glucose should be fixed. So that's how you titrate the fasting plasma glucose. So daily self-monitoring of fasting plasma glucose. Patient self-monitors fasting plasma glucose daily. Increase the basal dose by 2 units every 3 days until the fasting plasma targets is achieved. That is nothing but 80 to 130 milligram per deciliter is reached without any hypoglycemia. So patient we have given information to the patient and patient is titrating. So 1 to 3 days patient's FPG was 185, patient increased the dose by 2 units. So now the dose is 14. It was initially he started 12, now it is become 14. So from days 4 he again measured the FPG and it was 160. So he increased by 2 units and the dose became 16 units. Day 7th again he measured, still it was above the target, it was 142. So again he increased the dose by 2 units and it became 8 units. Day 10th he measured, so every 3 days he is measuring. So day 10th it is 115 milligram per deciliter. Now the target is achieved. So now the patient is on maintenance of 18 units. Now one point the patient should be informed that patient if he experienced any unexplained hypoglycemia, meaning the fasting plasma glucose if it touches less than 70 milligram per deciliter, decrease the dose by 10 to 20% or 2 to 4 units immediately. That this information should be given to the patient. So now we have achieved the target of fasting plasma glucose. Now we should achieve the target of HbA1c now. That is the step 3. So 3 months later we should calculate HbA1c. So that is the rule. 3 months later we should calculate. So now after 3 months the fasting plasma glucose is approximately 110 milligram per deciliter, but the HbA1c is 8.2%. So it is decreased from 9.5% to 8.2, but still the target is not met. So target is less than 7%. Conclusion. So elevated HbA1c despite fasting control means the post-prandial glucose is the issue. Okay. Now the phase 3 is add prandial insulin. So add prandial bolus insulin to the largest meal of the day. Here our patient takes his largest meal in the lunch. So we will start the prandial insulin in the lunch now. So which insulin we are using? Rapid acting analog. So insulin Lispro or Aspart we are using. Starting dose, either we will use 4 units or 10% of the basal dose. So basal is 18, 10% of this is 1.8, that is approximately equal to 2 units. Either we are using 4 units or 2 units. So 4 units is standard safe starting dose. Now new prescription, insulin Lispro 4 units subcutaneously before the lunch, 15 minutes before the lunch, and maintain glargine at 80 units at bedtime. So now you have started the prandial insulin. Now we will titrate the prandial insulin dose, so that the 2-hour ppbs or the 2-hour ppg postprandial glucose becomes less than 180 mg per deciliter. Till this time we will titrate. So increase the prandial glucose by 1 to 2 units every 3 days until the post meal or next pre-meal. I said no, either you will see post 2-hour meal, 1 to 2-hour meal, or next pre-meal target. Pre-meal target, remember, it is less than 130, and post meal target is less than 180. You should remember this. Okay, so these targets should be met. Now patient is given information. So now patient on week 1 his 2-hour post lunch glucose was 240, so he added 2 units and it became 6 units. So in the second week again he measured. So in the second week, at the second means in the fourth day he measured the 2-hour glucose and it was 210, so he increased by 2 units and it became 8 units before lunch. In the next 3 days, meaning at the 10th day it was 195, so still the target is not achieved. So he increased by not 2 units, he increased by 1, because it is very much closer to our target of 180. So it became 9 units. At the you can say at the 13th day, patient measured it and it was 165, 2-hour. So the target is achieved and patient is on maintenance of 9 units. Now the next step is, again after 3 months you will calculate the HbA1c, and if the HbA1c is met with the target, then okay, maintain the prandial before lunch dose and basal insulin dose of 8 units, and if still it is not maintained, then you will add the prandial glucose in the next largest meal of the patient. So here the first largest meal was lunch, next it will be like morning. Again, if still it is not measured, then it will go to evening. Okay, so that's how we calculate. And one thing we should remember always, the morning prandial insulin will affect the pre-meal glucose level of lunch, and the lunch prandial insulin will affect the pre-meal insulin level of the dinner, and basal insulin level affects the pre-fasting plasma glucose. So accordingly we should titrate the insulins. Okay, and in other ways morning prandial insulin will affect the 2-hour postprandial glucose level of the morning. Lunch prandial glucose will affect the 2-hour postprandial glucose level of the lunch. Evening prandial glucose level will affect the 2-hour postprandial glucose level of the evening. Okay, these methods, either you will measure the pre-meal or the post-meal of that meal. That's how you titrate. So in this patient, so this is now patient is taking 9 units before lunch and 18 units as bolus now. So what are the next steps in clinical progression? Optimize the basal, 1 dose prandial. Now it is optimized. If HbA1c remains more than target after 3 months, then add second prandial insulin to the second largest meal. Finally, it will be to all the 3 meals, then full basal bolus regimen. Okay, this is the method how we start the insulin dose and how we titrate and how we achieve the target. So this is the easiest method. I am not discussing the advanced method, but this is the method, traditional method, which is used. Okay, if you have not understand, you can go and watch the video one more time. Okay, so that's enough for today. We will meet in the next video. Thank you.